मेरे प्यारे बच्चों, hello my dear loving students, how are you all? So as you all know, today's session is about 25 clinical questions of obs-gynae. So we will be discussing and I will try my level best to cover obs and gynae in these 25 questions. With the explanation of these 25 questions, I will try my best to help you to crack various questions on 4th June exam. So it is not only a discussion of these 25 clinical questions, but I will try to cover as much text as possible with various clinical explanations, various image sessions, and various demonstrations. So let's begin with our question number 1. Question number 1, all of the following are correct about abruptio placentae except. So first question I have taken from accidental hemorrhage. Accidental hemorrhage is also called abruptio placentae. So another name of accidental hemorrhage is abruptio placentae. Fine. Good evening everybody. Prabhada, Rao Saab, Deepak, Thanzi, Dipinder, Sheikh, Lokesh. Good evening everyone. A very good evening to everyone. So with the question number 1, all of the following are correct about abruptio placentae except. Option A, dark colored amniotic fluid. What comes to your mind? Come on, let's interact. Dark colored amniotic fluid. What comes to your mind? Yes, Thanzi, Dipinder, Rao, Sujit, Lokesh, Sheikh. Is it correct statement or not? What colored amniotic fluid is seen in abruptio placentae? We have discussed in our classes also, and you know, dark colored amniotic fluid is seen in abruptio placentae, and can you tell me the reason for this? Why amniotic fluid is dark colored in abruptio placentae? Can anyone answer this? Why amniotic fluid is dark colored in abruptio placentae? I will answer you. It is due to thromboplastin. Thromboplastin, which is released after separation of placenta, which gives it dark color. Option B, so this is the correct statement. Option B, uterus is hard and tender. Fetal heart sound may not be auscultated, and this condition may lead to uteroplacental apoplexy. Correct or incorrect? This is also a correct statement. After abruption, because of release of thromboplastin, uterus becomes hard and tender because thromboplastin is uterotonic. Thromboplastin increases tone of uterus. This is the reason after abruption of placenta, abdomen and uterus feel hard and tender. Why abdomen and uterus feel hard and tender after separation of placenta? Because of release of thromboplastin. Thromboplastin gives dark color to amniotic fluid. Thromboplastin makes abdomen and uterus hard and tender. So this is the correct statement. Fetal heart sound may not be auscultated because abdomen is hard. May lead to uteroplacental apoplexy. This is also correct. Another name of uteroplacental apoplexy is Cavalier Uterus. What's another name of uteroplacental apoplexy? It's Cavalier Uterus. What is Cavalier Uterus or uteroplacental apoplexy? After separation of placenta, this retroplacental blood enters myometrium and reach up to outermost layer of uterus, that is serosa. This is called Cavalier Uterus, and another name of Cavalier Uterus is uteroplacental apoplexy. So this is also a correct statement. Management is immediate induction of labor. This is also correct statement. Why immediate induction of labor is advised in abruptio placentae? Because of risk of DIC, disseminated intravascular coagulation. And risk of disseminated intravascular coagulation after abruption of placenta is again due to release of thromboplastin. This thromboplastin enters maternal circulation and results in disseminated intravascular coagulation. So option A is correct, option B is correct, option C is correct. Let's have a look at option D. Positive style-worthy sign. Style-worthy sign is seen in type 2 posterior placenta previa, type 3 posterior placenta previa, type 4 posterior placenta previa. And what is this style-worthy sign? This style-worthy sign, I would like to demonstrate you. What is this style-worthy sign? Style-worthy sign is if fetal head is pushed in pelvis. If fetal head is pushed in pelvis, if you try to push the fetal head in pelvis, fetal heart rate drops. And as soon as the pressure is released, fetal heart rate becomes normal. Because type 2 posterior placenta, type 3 posterior placenta, and type 4 posterior placenta, they are in front of sacral promontory. And when fetal head enters pelvic inlet, this placenta is sandwiched between sacral promontory and fetal head. This is why, because placenta is compressed, blood supply to fetus is reduced, which results in fetal distress, resulting in reduction in fetal heart rate. This is called Stahlworthy sign. So Stahlworthy sign is seen in type 2 posterior placenta previa, type 3 posterior placenta previa, and type 4 posterior placenta previa. So Stahlworthy sign is seen in placenta previa and not in abruptio placentae. So incorrect statement is Stahlworthy sign. Fine. So this is the correct answer. We have to choose the incorrect statement. So answer to this question is D. Fine. Second question. I'm not able to see the, Type 2 posterior placenta previa, very good, very good, very good, very good, very good, all very nice. I'm so happy all of you are interacting so well. Dr. Dopamine, thank you so much. You said positive personality, great, thank you so much. We all are positive, yaar. We all are positive. पॉजिटिव कहां से बनते हैं यार? अपने विचारों से. वो कहते थे ना, मन के जीते जीत है और मन के हारे हार. हार और जीत तो बेटा मन से है. अपने मन को बुलंद कर लो, अपने मन को मजबूत कर लो, ये दुनिया तुम्हारी होगी. ये दुनिया तुम्हारी होगी. सिर्फ मन, बिलीफ सिस्टम, केवल एक बिलीफ. पता है एलन मस्क? डू यू नो समथिंग अबाउट एलन मस्क? When Elon Musk was a child, his parents took him to doctor that Elon Musk is not able to hear anything. Elon Musk सुन नहीं पाता, इसका कान खराब है. They went to doctor and doctor operated the ear. But ear was normal. The problem is, when Elon Musk was studying anything, Elon Musk was going through any literature, he was so focused. He was so focused that he didn't hear any voice. So this is focus, beta. This is concentration. This is consistency which makes us positive. 10 दिन बचे हैं. 10 days left for FMGE exam. फोड़ के रख देंगे हम. 10 दिन में तो आग लगा देंगे. जब चाय के, कॉफी के, टेबल से लेके होठों तक पहुंचने में दुनिया बदल सकती है, तो 10 दिन में तो रिजल्ट बदल के रख देंगे. In 10 days, we will do a lot. With these 25 questions of obs-gynae, I will try my level best today to contribute something in your life. So we are done with question number 1. Question number 2. एक और किस्सा सुना देता हूं. स्वामी विवेकानंद. When Swami Vivekanand was studying something on a street, he was a very poor person. He was studying something on a street and some procession passed by. And people asked him, there was some procession. Vivekanand said, which procession? I don't have any idea. I am unaware of it. विवेकानंद जी को पता ही नहीं चला कि पूरी की पूरी बारात उनके बराबर से निकल गई. वो इतना फोकस थे, इतना कंसिस्टेंट थे पढ़ने में कि उन्होंने उस पर ध्यान ही नहीं दिया. इन 10 दिन बेटा, इन 10 दिन केवल अपनी पढ़ाई पर ध्यान देना, केवल अपने रिवीजन पर ध्यान देना, बाकी सब कुछ भूल जाना. लेजर का फोकस रखो, लेजर का. यू नो, लेजर फोकस. एक बात बताता हूं छोटी सी. जंगल का राजा कौन है? जंगल का राजा शेर है. लोग कहते हैं ना, शेर जंगल का राजा है. Lion is the king of forest. Who said? Was some election conducted? कोई इलेक्शन हुआ था जंगल में जिसमें शेर को जंगल का राजा बनाया? नहीं. शेर जंगल का राजा है क्योंकि शेर मानता है कि मैं जंगल का राजा हूं. शेर मानता है कि मैं जंगल का राजा हूं, इसलिए शेर जंगल का राजा है. कोई इलेक्शन नहीं हुआ था. बच्चों, अगर तुम मानते हो कि तुम 4 जून को पास हो जाओगे, तो तुम 4 जून को पास हो जाओगे. इन 10 दिन केवल पूरी शिद्दत के साथ पढ़ाई कर लेना, रिवीजन कर लेना. जो पढ़ा है, जो पढ़ रहे हो, उसको रिवाइज कर लेना. 100 जगह गड्ढे खोदने से कुछ नहीं होगा. एक ही जगह 100 फुट गड्ढा खोद दो, पानी की बौछारें निकल के आ जाएंगी. लेट्स कम टू क्वेश्चन नंबर 2. Color Doppler studies in a patient with filamentous insertion of umbilical cord revealed fetal vessels which were overlying internal os. Which of the following is false regarding her condition? So this question is about filamentous insertion of umbilical cord. And we all know what is the filamentous insertion of umbilical cord. Let me show you an image of filamentous insertion of umbilical cord. This is the filamentous insertion of umbilical cord. What happens here? This is filamentous insertion of umbilical cord. This is the umbilical cord, beta, and this umbilical cord is not inserted on placenta. Rather, it is inserted away from placenta. It is inserted away and then it is passing through the membranes and reaching placenta. This is called filamentous insertion of umbilicus cord. Filamentous insertion of umbilical cord. What is the drawback of filamentous insertion of umbilical cord? It can lead to vasa previa, where fetal vessels are lying lower down, near internal os. This is called vasa previa. And because of this vasa previa, there can be bleeding per vaginum, and this bleeding per vaginum is fetal in origin. It is fetal in origin, so fetal blood is coming out of vagina. So we should know whether the blood which is coming out of vagina is fetal in origin or maternal in origin. Because if it is fetal in origin, we have to go for immediate cesarean section. Otherwise, this fetus will die due to fetal distress. So we should know how we can diagnose this condition. Filamentous insertion of umbilical cord can be diagnosed by color Doppler ultrasound. While the blood which is coming out of placenta, whether it is fetal in origin or maternal in origin, it can be diagnosed by what? It can be diagnosed by what? Tell me. It can be diagnosed by which test? The blood which is coming out of vagina, whether it is fetal in origin or maternal in origin, it can be diagnosed by which test? It can be diagnosed by Singer's alkali denaturation test or F test. Very important test for exam. What is the reagent used in the test? 10% potassium hydroxide. What is the principle of this test? Fetal hemoglobin is resistant to alkali. So had it been fetal blood, it won't be denatured. And had it been maternal blood, it would be denatured. So whether the blood which is coming out of vagina is fetal in origin or maternal in origin can be diagnosed by Singer's alkali denaturation test or F test. That's fun. Diagnosis of vasa previa can be done by color Doppler ultrasound. Color Doppler ultrasound. Fine. Okay, good. Very nice, very nice, very nice, very nice. So let's come back to the question. Very good. All of you have answered B. I am so happy. I am so happy all of you have answered B. So color Doppler studies in a patient with filamentous insertion of umbilical cord revealed fetal vessels which were overlying internal os. Which of the following is false regarding her condition? Option A, risk of fetal distress. That's correct, beta. We discussed it. Vasa previa, which is diagnosed by Singer's alkali denaturation test. No, beta. Singer's alkali denaturation test gives us idea about the blood, whether the blood which is coming out of vagina is fetal in origin or maternal in origin. Vasa previa is diagnosed by color Doppler ultrasound. So incorrect statement. C, management is by cesarean section. Yes. Cervical dilatation or membrane rupture can predispose bleeding per vaginum. Yes. So answer is B. Very good. Wonderful. Wonderful. I am so happy all of you have answered B. Very nice. Let me show you various types of placental abnormalities quickly. Quickly, I will go through something. This is the circumvallate placenta. What is this placenta, beta? This is the circumvallate placenta. Circumvallate placenta, this is the fetal surface. And fetal surface of placenta is smaller than maternal surface. With a valve-like thickening, we have discussed beautifully in our classes, with a valve-like thickening at the junction of fetal and maternal surface. So this is the circumvallate placenta. Which one? Circumvallate. Let me show you another one, and I would like to ask you, what is this? Give me the answer. Give me the answer. First of all, quiz. Which surface of placenta is this? Maternal surface or fetal surface? Come on, everyone. Which surface of placenta is this? Is it the maternal surface or the fetal surface of placenta? Fetal surface has umbilical cord, while maternal surface has cotyledons, lobules. So which surface is this? Maternal or fetal? Maternal surface has cotyledons or lobules, while fetal surface, umbilical cord is attached to fetal surface. So this is maternal surface of placenta. Very good. Beautiful. Another abnormality of placenta, let's go through it quickly. Another abnormality of placenta, tell me what is this? Everyone, come on. Everyone, tell me which abnormality of placenta is this? Which one? See, this is the main lobe. This is the main lobe, while this is the accessory lobe of placenta. And if there is an accessory lobe, and accessory lobe is small, which is connected by these blood vessels, this is called subcenturiate lobe of placenta. So this is subcenturiate placenta. What is placenta spuria? A smaller accessory lobe, but not connected by blood vessel. What is placenta bilobata or placenta bipartite? Two equal sized lobes. Two equal sized lobes. Wonderful. Okay. Let's go move to question number 3. A 30-year-old primipara lady, okay, her age is 30 and she is a primipara, fine, with gestational diabetes. She is having gestational diabetes mellitus, started having severe bleeding per vaginum following delivery of placenta. So after delivery of placenta, she is complaining severe bleeding per vagina. And she is a primipara lady, so she is a primipara. Although PPH is more common in multipara, but this lady is a primipara and complaining of severe bleeding per vaginum after expulsion of placenta. Abdominal examination revealed soft uterus. Okay. Otherwise, after delivery of placenta, uterus should be firm, globular, like a cricket ball field. What is the abdominal sign of placental separation? Firm, globular, cricket ball field of uterus. But this is a soft uterus. This is something which we don't want. We want a firm, globular, cricket ball feel of uterus. All of the following are correct about this condition in her except. So don't miss to see the except beta. Don't commit silly mistakes in questions. Always see except. Always see if the question is which of the following is not like that. So this is the case of postpartum hemorrhage. And why there is postpartum hemorrhage in this condition? Can anyone answer me? I am waiting for your answers. I am waiting for your answers. Can anyone tell me? Can anyone tell me why? Why this lady is having postpartum hemorrhage? Chocolate. Chocolate for the correct answer. I got multiple chocolates, you know. One chocolate for the correct answer, and then you can text me after the class. You can text me after this session, and you can collect your chocolate. This is my phone number. 7042109992. 7042109992. After the completion of the session, you can text me and you can collect your chocolate for the correct answer. Fine. Why she is having postpartum hemorrhage? Can anyone tell me? She is a primipara with gestational diabetes mellitus. No uterus stone, yes, no uterus stone, but why? What is the cause of PPH? Very good. Dr. Nisha, Dr. Prerna, wonderful. Nisha, Prerna, correct answer. Bhajan, correct answer. Dhaval, correct answer. I wanted the word macrosomia. Satish, macrosomia. I wanted the word Sujit, macrosomia. I wanted the word macrosomia. This is why she is having postpartum hemorrhage, because macrosomia occurs in fetus of a diabetic mother. And what is the reason for macrosomia? What is the name of the hypothesis? Pedersen hypothesis. Maternal hyperglycemia, and this glucose passes through fetus via placenta. So fetal pancreas starts secreting excessive insulin, and fetal growth is governed by insulin. Which hypothesis is this? This is Pedersen hypothesis. This is Pedersen hypothesis. And because of big fetus, you know, because of the big fetus, macrosomia, there is more pressure, early pressure. More pressure, early pressure. And what is happening? Because of this big fetus, macrosomia, uterus is distended. Uterus is distended for a longer time. It is over distended. And if a rubber band is stretched for a longer time, does it regain its original tensile strength? No, it does not regain its original tensile strength. This is what happens here. This is the reason for uterine atony. This is why there is no tone in the uterus here. And this is the reason for postpartum hemorrhage. Most common cause of postpartum hemorrhage is uterine atony. What is the most common type of postpartum hemorrhage? Primary postpartum hemorrhage. So, because of this diabetes, polyhydramnios occurs. Yes, polyhydramnios results due to diabetes, osmotic diuresis. Macrosomia, correct. Drug of choice to treat this condition is oxytocin, 30 to 40 international units by slow IV infusion. Correct in statement. What is the drug of choice to treat postpartum hemorrhage? Drug of choice to treat postpartum hemorrhage is oxytocin, 30 to 40 international units by slow IV infusion. Important chocolate question for our exam. This option C itself is a very important chocolate question for our exam. Answer me one question. What is the prophylactic drug of choice for PPH? This is the therapeutic drug of choice. What is the prophylactic drug of choice for postpartum hemorrhage? Anyone? Come on, quickly. What is the prophylactic drug of choice for postpartum hemorrhage? Yes, Nawab, Vijay, Renu, Knowledge, Kumar, Salima, Ramya, Pragya, Alia, John, Nilesh, Neha, Ishan, Karishma, Sushma. Drug of choice, prophylactic drug of choice, Ravlika, oxytocin, Prerna, oxytocin, wonderful. So be very clear, I am repeating these three important chocolate questions of our exam. Question number 1, prophylactic drug of choice to treat postpartum hemorrhage, oxytocin, 10 international units, intramuscular injection. Question number 2, therapeutic drug of choice for postpartum hemorrhage, oxytocin, 30 to 40 international units by slow IV infusion. Question number 3, best drug to treat postpartum hemorrhage or most potent drug to treat postpartum hemorrhage. But now the question is carboprost. Carboprost is also called Hembate and the compound is 15-methyl PGF2 alpha. So we have three important, not important but very important chocolate questions for our exam. I will repeat. I am expecting one of these three on 4th of June. Prophylactic drug of choice for postpartum hemorrhage, oxytocin, 10 international units, intramuscular injection. Therapeutic drug of choice for postpartum hemorrhage, oxytocin, 30 to 40 international units by slow IV infusion. Best drug to treat postpartum hemorrhage, carboprost or Hembate, and the salt is 15-methyl PGF2 alpha. Option D. Management is immediate subtotal hysterectomy. Beta, what is the management protocol of postpartum hemorrhage? First of all, we treat her shock, resuscitate the patient. Then to control bleeding, what is given? Injection tranexamic acid, 1 gram by slow IV injection. Then therapeutic drug of choice, oxytocin, 30 to 40 international units by slow IV infusion. And when you are giving oxytocin, at the same time, you are giving a uterine massage. So uterine massage is given along with oxytocin. If there is no response, then we give carboprost. Other drugs, misoprostol, methyl ergometrin can also be tried. If there is no response by medical management for 30 minutes, then we go for uterine tamponade. We use either a Bakri balloon catheter or a condom catheter or Sanjastic and Blackmore esophageal catheter. And we put them in uterine cavity and fill 300 to 500 ml of warm saline. If there is no response with uterine tamponade, then we switch over to external aorta compression or bimanual compression or military anti-shock garments. If there is no response, then if she is a multipara, we go for subtotal hysterectomy. If she is a primipara, then we go for B-Lynch sutures or brace suture. If no response, then uterine artery ligation. If no response, ovarian artery ligation. If no response, ligation of anterior division of internal iliac artery. So this sequence is also very important, beta. What is the correct sequence of devascularization of vessel? First of all, uterine artery. If no response, ovarian artery. If no response, ligation of anterior division of internal iliac artery. If no response, then we go for hysterectomy, subtotal or supracervical. In postpartum hemorrhage, which hysterectomy is done? Subtotal or supracervical hysterectomy is done. If there is no response even after this hysterectomy, we pack, umbrella pack or parachute pack. So in primipara, we do hysterectomy after failure of external aorta compression, military anti-shock garment, and bimanual compression. In multipara. In primipara, we don't do hysterectomy there. And she is a primipara lady because she wants future childbearing. So in primipara beta, management can never be immediate subtotal hysterectomy. So this is the incorrect statement. Incorrect. Let's move to next question. A 28-year-old lady. Okay, her age is 28. In a 28-year-old lady, third stage of labor was managed in a hurry. Third stage of labor was managed in a hurry without pushing uterus cephalad while doing umbilical cord traction. While doing umbilical cord traction, uterus was not pushed cephalad. Okay. Within a few minutes, uterus was seen turning inside out. Within a few minutes, uterus was seen turning inside out. Then she developed hypotension. Tachycardia means she is developing shock and went into shock. Examiner has clearly used the word shock. Which of the following is correct regarding this condition? What comes to your mind, beta? What comes to your mind? What comes to your mind? Rumani, Ankit, Sheikh. Rumani says D, uterine prolapse. Which of the following is correct regarding this condition? What is this condition, first of all? Can you name the condition? Can you name the condition? What is this condition? What is happening to her? What has happened? Let me show you first what is the question. The question clearly says that uterus was not pushed cephalad. Let me first of all show you what's happening here. What's happening? The question clearly says that when you are removing the cord, so what has happened? Fetus is out. Now you are taking out the placenta. And how we take out the placenta? Whenever we take out the placenta, we pull the cord. We pull the cord. And when we are pulling the cord, beta, how the cord is pulled? When we are pulling the cord, at the same time, uterus is pushed cephalad. This is called controlled cord traction. And another name of controlled cord traction is modified Brand and Reuse technique. And if controlled cord traction is not given, means if uterus is not pushed cephalad, what can happen, beta? Uterus may turn inside out. This is called uterine inversion. What is this called? Uterine inversion. So uterine inversion is due to mismanaged which stage of labor? Uterine inversion is due to mismanaged third stage of labor, while uterine prolapse is due to mismanaged second stage of labor. I repeat, beta. Uterine inversion is due to mismanaged third stage of labor, while uterine prolapse is due to mismanaged second stage of labor. So what we are dealing with? We are dealing with uterine inversion because controlled cord traction was not done. This is why uterus has started turning inside out. Let's come back to our question. Let's come back to the question, beta. Fine. Vijit third, abar B, Jivitha 3. Third, very good, very good. So uterine inversion is due to mismanaged third stage of labor. So we are dealing with uterine inversion. And what happens in uterine inversion, beta? In uterine inversion, most common cause of pain is neurogenic shock, while most common cause of death in uterine inversion is hemorrhagic shock. Two important questions, beta. Most common cause of pain in uterine inversion is which shock? Neurogenic shock. Most common cause of death in uterine inversion is hemorrhagic shock. Let me give you three very, very important chocolate questions. Question number 1. Most common cause of shock after delivery. Can anyone answer? Most common cause of shock after delivery. Very important chocolate question for our exam. Most common cause, yes, obstetric shock, yes, hemorrhagic shock. Very good, very good. Neha, Pragya, Alia, Bolabona, I'm so happy with your participation. I'm so happy that all of you are understanding the concepts very well. Vittu, very nice, wonderful. So most common cause of shock after delivery, postpartum hemorrhage. Postpartum, very good. Donald Trump has answered correctly, postpartum hemorrhage. Now let's see what Biden answers, what Putin answers. I'm waiting for Putin and everyone. Boris Johnson will also come now. Fine. Okay, so Donald Trump, I am so happy your chocolate is with me. Okay. Now, most common cause of shock after delivery, postpartum hemorrhage. Question number 2. Most common cause of shock immediately after delivery. Come on, everyone. I have just added the word immediately. Most common cause of shock immediately after delivery. Can anyone? Waiting. I want to give the chocolate. Most common cause of shock immediately after delivery. I have changed the question. Question number 1 was most common cause. Yes, this is a NEET PG 2022 question regarding the controlled cord traction, and I will come to that question once again. Yes, very nice. You have gone through the NEET 2022 question also. I have taken this question from NEET PG 2022, that is day before yesterday's question. Wonderful. I'm so happy that all of you are going through that. Very good. No. But I want that answer, Most common cause, no, amniotic fluid embolism is not the answer to this. Most common cause of shock immediately after delivery is uterine inversion. Yes, Rizwana, this is your chocolate. Most common cause of shock immediately after delivery is uterine inversion. Question number 3. Most common cause of unexplained shock after delivery. Come on, everyone. Most common cause of unexplained shock after delivery is amniotic fluid embolism. So we have 3 questions, 3 chocolate questions, 3 very important chocolate questions for 4th June exam. I repeat, because I am expecting one of them on 4th of June. Most common cause of shock after delivery, postpartum hemorrhage. Question number 2. Most common cause of shock immediately after delivery, uterine inversion. Question number 3. Most common cause of unexplained shock after delivery, amniotic fluid embolism. Fine. So let's come back to this question. Which of the following is correct regarding this condition? This is uterine inversion. This is not amniotic fluid embolism. Most common cause of pain in this condition is neurogenic shock, because this is the case of uterine inversion. So this is the correct statement. Atonic postpartum hemorrhage. No, this is not atonic postpartum hemorrhage, beta. Why? Why this is not atonic postpartum hemorrhage? Because it is clearly written that uterus was seen turning inside out. In postpartum hemorrhage, uterus is not turning inside out. It is not turning inside out. Clear? So this is not postpartum hemorrhage. Then it is clearly written that uterus was not pushed cephalad while pulling the cord. Uterine prolapse. This is not uterine prolapse. Prolapse is due to mismanaged second stage of labor, and prolapse doesn't happen immediately. It is a long-term complication of mismanaged second stage of labor, while uterine inversion is immediate complication of mismanaged third stage of labor. So answer here is B. Let's come to the next question. A 27-year-old lady. Fine. Her age is 27. Presented with complaints of amenorrhea for 7 weeks. Okay, fine. And history of previous tubal surgery. Amenorrhea for 7 weeks and history of previous tubal surgery. So if you see this word, history of previous tubal surgery, where did we write this line in our notes, in our classes? Most common risk factor for ectopic is history of previous ectopic. And second most common risk factor for ectopic pregnancy is history of previous tubal surgery. Serum beta HCG levels were estimated in her after 48 hours. Which of the following findings will increase the suspicion of ectopic gestation? Very important question, beta. Again, there was a similar question in NEET PG 22 on 21st of May. Why I have taken few questions from there, not few, I have taken the juice of NEET PG 2022 obscini question, because the question paper setter, the body is same, so we should know the concept. Question will not be repeated same. Question will not be repeated as it is. We should know the neighbors of the questions also. We should know the explanations, and we should know the concept related to this question as well. So what is the concept here, beta? Concept here is, if you are doing HCG estimation now, and if you are repeating HCG after 48 hours, tell me, I am asking you 3 questions now. If you take her blood now, beta, and if you repeat HCG after 48 hours, what is the normal doubling time of HCG? Again, an important chocolate question. What is the normal doubling time of HCG? It is 48 hours. So if you take her blood now, and if you repeat this HCG test after 48 hours, if HCG doubles after 48 hours, tell me, what comes to your mind? I am asking a different question. Write the word, if HCG doubles after 48 hours. No, it is not ectopic, yaar. It is not ectopic if HCG doubles after 48 hours. If HCG doubles after 48 hours, normal pregnancy double. Master Rahul Hitesh Kumar, this chocolate is for you. Master Rahul Hitesh Kumar, this chocolate is for you. Normal doubling time of HCG is 48 hours. So if HCG doubles in 48 hours, this is clearly indicating a little late developing normal intrauterine pregnancy. So this is not ectopic. If it is an ectopic pregnancy, HCG will increase after 48 hours, but it will not double. And if HCG has started falling after 48 hours, it indicates abortion. So we have three very important MCQs, and the similar question was asked on 21st May, NEET PG 22 also. I repeat, beta, I'm expecting one of them on 4th of June, important chocolate question. If you take her blood, estimate HCG now. Repeat HCG after 48 hours. If it doubles, it is indicating late developing normal intrauterine pregnancy. If HCG increase but does not double, ectopic pregnancy. If HCG falls, abortion. So HCG increase but does not double, this is indicating ectopic. HCG levels decrease, this indicates abortion. HCG levels double after 48 hours, it indicates normal intrauterine. HCG levels are markedly elevated. If HCG levels are markedly elevated, beta, this could be a molar pregnancy. This could be a hydatidiform mole, because hydatidiform mole is abnormal proliferation and degeneration of chorionic tissue. So this is not hydatidiform mole. Question is clear-cut about what will be the suspicion of ectopic gestation in her. So ectopic is if HCG is increasing, but it is not doubling. I repeat, before moving to next question, the important chocolate question, how much is the doubling time of HCG? 48 hours. Fine. Next question, beta. Before next question, a small message from my side. 10 days left for FMGE exam. A lot can happen with focused approach. Acclimatize your clock according to exam day. Means you should start waking up somewhere around 5 o'clock or 5:30 a.m. in the morning and go to bed somewhere around 11 or 11:30. It doesn't mean you have to sleep at 11 or 11:30. Just go to bed and switch off the lights. Acclimatize your clock according to exam day, because on exam day, beta, you will wake up at 5 o'clock. Your centers may be little far and you will have to travel. You will recheck your documents once again. And try to have similar kind of breakfast and meals as you will be taking on exam day. And a very important message is solve all tests while sitting on chair. While sitting on chair with proper trace and shoe. Because on the day of exam, you will be wearing shoes. And what happens, beta, whenever we are giving any subject-wise test or a topic-wise test or a mock test, we are lying with the laptop and all that. So please don't do it. Maintain proper attitude, maintain proper position. And of course, have nutritious diet, including fruits, salads, and dry fruits. Let's move to next question. A 26-year-old lady. She is a 26-year-old lady who presents with history of amenorrhea for 8 weeks. She presents with history of amenorrhea for 8 weeks and a positive urine pregnancy test. So she is pregnant, her urine test is positive, and amenorrhea is for 8 weeks. She complained of lower abdominal pain. Fine, 8 weeks amenorrhea, urine test positive, lower abdominal pain. Transvaginal sonography detected ectopic pregnancy without any free fluid. Ectopic pregnancy without any free fluid in peritoneal cavity. Means this is an unruptured ectopic. If ectopic will rupture, beta, there will be free fluid in peritoneal cavity. And what is this free fluid? This will be blood, hemoperitoneum. So there is no free fluid in peritoneal cavity, means it is a case of unruptured ectopic pregnancy. Which of the following is an indication for medical management in this patient? So examiner is clearly asking about indication of medical management in this ectopic pregnancy. Initial serum beta HCG level of 600. Let me see what you're saying. Renu B, Nisha B, Sujit B, Ranveer B, Manoj B, Rumani B, Bhajan A, Divya A, Prerna D, Ishan B, B, A. Why you are thinking A and D? Let me explain you. to clear your confusion. What is the indication of medical management? Let me summarize the indication of management of ectopic. Very important MCQ zone for our exam. Expectant management is done if beta HCG levels are less than 1000. Medical management if HCG levels between 1000 and 5000. Ectopic mass size less than 4 cm and cardiac activity absent. Surgical management, beta HCG more than 5000, ectopic mass size more than 4 cm, cardiac activity present, or if there is no response to medical management. So this is how we categorize 3 types of management in ectopic pregnancy, that is expectant management, medical management, and surgical management. Let's have a look at the options. Initial serum beta HCG level of 600. So this is the indication of expectant management. Expectant management is done if HCG levels are less than 1000. Initial serum beta HCG level of 1700 international units per liter. This falls under the category of medical management, correct. Ectopic mass size 6 by 5 centimeter, no. Medical management is given if ectopic mass size is less than 4 centimeter, and if it is more than 4 centimeter, surgical management is done. Presence of fetal cardiac activity, surgical management. If fetal cardiac activity absent, medical management. So ectopic mass size, this is not. So correct answer is B. So I explained you the indication of expectant management, medical management, surgical management of ectopic pregnancy. Obstacles of today are not altogether for today. It is for a vast future. It is for a vast future. It doesn't mean that if you are feeling any hardship, any obstacle, that it is for today only. You will remember this time for your lifetime. All of you consider yourself to be in Gurukul. This is a Gurukul. This is a Gurukul study. You know, all the kings, all the emperors, they used to send their children to forest, to Gurukul, because that was the place where they could be groomed in a proper way. Obstacles, struggles are part of our life. And how to emerge smartly, this is called art of life. So we should know art of living our life, and you will remember this time for your lifetime, because it is building up your future. It is for your vast future. So don't get disheartened. हिम्मत मत हारना बच्चों. ये वक्त जिंदगी भर याद रहेगा. ये वक्त केवल अभी खराब नहीं लग रहा. ये खराब आज के लिए नहीं आया है. ये आगे आने वाली पूरी जिंदगी को सुनहरा बनाने के लिए आज थोड़ी सी हार्डशिप झेल लो, और इन 10 दिन पूरी शिद्दत के साथ, पूरी कंसिस्टेंसी के साथ, पूरे लेजर फोकस के साथ केवल पढ़ लेना और रिवाइज कर लेना. That's all. Let's move to another question. A 31-year-old lady. She is a 31-year-old lady, was brought to the emergency department with complaints of bleeding per vagina. Okay. 31-year-old lady, emergency department, bleeding per vagina, associated with abdominal pain and a history of amenorrhea for 7 weeks. So amenorrhea for 7 weeks, abdominal pain and bleeding per vagina. This is the case of ectopic pregnancy. Most common symptom in ectopic pregnancy is lower abdominal pain. Most common symptom in ectopic pregnancy, lower abdominal pain. What is the most common symptom in PID? Most common symptom in pelvic inflammatory disease is also lower abdominal pain. Then how to differentiate ectopic pregnancy and PID? In ectopic pregnancy, pregnancy test will be positive. In PID, pregnancy test will be negative. BP was 90 by 60, pulse rate was 146, and UPT was positive. She complains of shoulder tip pain also. What is the next step of management? So we are dealing with the ectopic pregnancy. How we get the clue that this is ectopic? Amenorrhea, lower abdominal pain. They are in favor of ectopic. Then this is the unruptured ectopic or a ruptured ectopic. Clearly written that vitals are not stable. She is hemodynamically unstable. Her BP is falling. So this is the case of ruptured ectopic pregnancy. How you get the clue of ruptured ectopic pregnancy in the question? Either BP will be less or the word shock will be written very clearly. What this shoulder tip pain indicate? This shoulder tip pain is Danforth sign. Because of massive hemoperitoneum beta, massive collection of blood in peritoneal cavity, which is irritating diaphragm, this pain is referred to shoulder. This is called Danforth sign, shoulder tip pain. And this is due to massive hemoperitoneum. So this is the case of ruptured ectopic pregnancy. What is the next step of management? Laparoscopic salpingo oophorectomy. First of all, laparoscopy is not done in ruptured ectopic pregnancy. If it is a ruptured ectopic pregnancy, it is a life-saving surgery. She is bleeding so profusely inside as if a tap is open. जैसे किसी ने नल खुला छोड़ दिया हो, इतनी ब्लीडिंग होती है बेटा अगर एक्टोपिक रप्चर हो जाए. सो इफ एक्टोपिक इज रप्चर्ड, हमको इमीडिएट लेप्रोटॉमी करना पड़ेगा. हम लेप्रोस्कोपी नहीं कर सकते. लेप्रोस्कोपी की प्रिपरेशन में वक्त लगता है. तो अगर एक्टोपिक रप्चर हो गया बेटा तो इमीडिएट लेप्रोटॉमी करना पड़ेगा. फाइन. सो लेप्रोस्कोपी इज गॉन. रिससिटेशन एंड इमरजेंसी लेप्रोटॉमी बिल्कुल ठीक है. वी विल डू दिस. एमनियो इन्फ्यूजन. Amnio infusion is done to treat oligohydramnios. Laparoscopic salpingostomy. If we are doing a laparoscopic surgery in an unruptured ectopic pregnancy, then this surgery is done laparoscopic salpingostomy. Laparoscopic salpingostomy means we don't suture the incision side. That is called ostomy. So laparoscopic salpingostomy is the management for unruptured ectopic pregnancy, while the management of ruptured ectopic pregnancy is immediate laparotomy. So amnio infusion is done to treat oligohydramnios. Laparoscopic salpingostomy, very important question for 4th June exam. It is the management of unruptured ectopic. But in this question, ectopic is ruptured, so the correct answer is resuscitation and emergency laparotomy. Parameter of your success by the way you struggle to overcome obstacles is greater than what you achieve, beta. What does it mean? तुम्हारी सक्सेस का, your success is determined by what? हमारी सफलता इस चीज से डिटरमाइन नहीं होती कि हमने क्या क्या पा लिया. हमारी सफलता इस चीज से मेजर होती है कि जब भी हमारी लाइफ में बुरा वक्त आया, जब भी हमारी लाइफ में स्ट्रगल आया, जब भी हमारी लाइफ में ऑब्स्टेकल आया, हमने उसको कैसे ओवरकम किया. हमने अपने आप को कितनी शिद्दत से उस चीज को फेस किया और कैसे हम उससे निकल के बाहर आ गए. ये आपकी सक्सेस के पैरामीटर का सही पैमाना है. आपने क्या क्या पा लिया ये तो वक्त बताने के लिए बहुत पड़ा हुआ है. इस वक्त में, इस टाइम पे डटे रहना, हिम्मत नहीं हारना, ये वक्त हमेशा याद रहेगा. ये वक्त कुछ देने के लिए आया है, बहुत कुछ देने के लिए आया है. ये वक्त हमको वो देगा जिसके सहारे हम अपनी जिंदगी में कभी रिटायर नहीं होंगे, कभी भी रिटायर नहीं होंगे. एक कलेक्टर, एक कमिश्नर, एक सुप्रीम कोर्ट, एक हाई कोर्ट, किसी के भी जज, कोई भी गवर्नमेंट ऑफिसर रिटायर हो जाएगा. लेकिन मेरे प्यारे प्यारे बच्चों, तुम जिंदगी के आखिरी दिन तक भी मरीज देख रहे होंगे, तुम कभी रिटायर नहीं होंगे. क्वेश्चन नंबर 8. A 34-year-old lady. Fine. A 34-year-old lady, her age is 34 years. Present in labor in cephalic presentation. Okay, she presents in cephalic presentation with bro as the presenting part. What is the longitudinal engaging diameter of fetal head in this condition? So what is the longitudinal engaging diameter of fetal head in this condition? Longitudinal engaging diameter of fetal head, if the presenting part is bro, is mento-vertical. Let me show you these two very important questions. What is the most common transverse engaging diameter of fetal head? Most common transverse engaging diameter of fetal head, beta, this is biparietal. Biparietal. Two important questions for 4th June exam. Chocolate question. Most common transverse engaging diameter of fetal head is biparietal. Question number 2. Most common longitudinal engaging diameter of fetal head. Most common longitudinal engaging diameter of fetal head is suboccipitobrachmatic. Suboccipitobrachmatic 9.5 centimeter. Biparietal 9.5 centimeter. Third important question. Largest longitudinal engaging diameter of fetal head, this is mento-vertical. Mento-vertical is from chin, junction of floor of mouth and chin to top of sagittal suture. This is called mento-vertical. This is the longest engaging diameter of fetal skull, and this is 14 centimeter. This is why, very important question, beta, if in any question, presenting part is bro, management will be cesarean section. In any question, if longitudinal engaging diameter is mento-vertical, management is cesarean section. Another chocolate question, how much is the dimension of mento-vertical diameter? 14 centimeter. So these three diameters are very, very important. I repeat, most common transverse engaging diameter of fetal head, biparietal, 9.5. Most common longitudinal engaging diameter of fetal head, suboccipito-brachmatic, 9.5. Third question, longest longitudinal engaging diameter of fetal head, mento-vertical, 14 centimeter. Mento-vertical diameter, what is the presenting part? Bro. And what is the management of bro? Caesarean section. How do you differentiate face, bro, and vertex? Face is bounded on one side by supraorbital ridges and root of nose, and on other side by junction of floor of mouth and chin. So this is face. This is bro. Bro is bounded on one side by supraorbital ridges and root of nose, and on other side by coronal sutures and anterior fontanelle. So this is bro. What is vertex? This is vertex. Vertex is bounded on one side by coronal suture and anterior fontanelle, on other side by lambdoid suture and posterior fontanelle, and laterally bounded by imaginary lines passing through parietal eminence. So this is face, this is bro, and this is vertex. So if it is bro, management will be caesarean section. Let's come back to the question. So a 34-year-old lady presents in labor in cephalic presentation with bro as the presenting part. What is the longitudinal engaging diameter of fetal head in this condition? It has to be mento-vertical. Now, suboccipito-brachmatic will be answer to which question? Most common longitudinal engaging diameter of fetal head, suboccipito-brachmatic. Why it is most common, beta? We have discussed in our classes. If head is completely flat, and what is the most common attitude of fetus? Most common attitude of fetus is flexion. Another chocolate question for our exam. What is the most common attitude of fetus? Flexion. Because it is flexed inside. It is flexed inside because there is less space inside. Fine. Biparietal is answer to which question? Most common transverse engaging diameter of fetal head. So nobody would commit silly mistakes, beta. Nobody would commit silly mistake. I am repeating these questions, examination questions. Whatever we are discussing today, everything word by word is related to our exam only. I will not talk anything unimportant today. So most common longitudinal engaging diameter, I repeat, suboccipito-brachmatic. Most common transverse engaging diameter, biparietal. Super subparietal transverse engaging diameter is possible in which pelvis? Can anyone answer this question? Chocolate question. Question for the chocolate. Super subparietal transverse engaging diameter. Super subparietal transverse engaging diameter is possible in which pelvis? This is not this question. I am asking you, chocolate question. Yeah, Sudipta, it is flexion. Kavita, vertex. Himanshu, flexion. Wonderful, very nice. Wasim, flexion. Dr. Ajay Devgan, yes, very good. Want to meet you, Dr. Ajay Devgan. I think I will meet Amitabh Bachchan also today. Very good. Vishnu Chinnu, good. Tell me the very good. Pushpinder Vashist, chocolate for you. Super subparietal transverse engaging diameter is seen in platypeloid pelvis. Pushpinder Vashist, your chocolate is due with me. Fine. Let's move to the next question. Consistency in these 10 days with laser focus can change outcome. I repeat, consistency in these 10 days with laser focus can change outcome. लेजर फोकस की तरह अपनी पढ़ाई और अपने रिवीजन को देखते रहो. 10 दिन में बहुत कुछ बदल सकता है, बहुत कुछ. किसी की मत सुनना, किसी पर ध्यान मत देना. केवल जो पढ़ा है उसको रिवाइज करते जाओ और कंसेप्ट्स को एब्जॉर्ब करते जाओ. कितना भी टफ क्वेश्चन आएगा, इन कंसेप्ट्स के बाहर कुछ नहीं आएगा. नेक्स्ट क्वेश्चन बेटा. 26-year-old lady with a history of obstructed labor. Her age is 26 and with a history of obstructed labor is being evaluated for a contracted pelvis. Okay. She is being evaluated for a contracted pelvis. CT scan pelvis shows both ala of sacrum to be absent. Okay, both ala to be absent. Which type of pelvis is this? Come on, everyone. Come on, everyone. Come on, everyone. Come on. Come on, everyone. Which type of pelvis is this? If both ala of sacrum are absent, come on. Come on. Come on. Which type of pelvis is this? Everyone is saying B. This is Robert's pelvis. If both ala of sacrum are absent, this is the case of Robert pelvis. If in this question, if one ala of pelvis absent, then if one ala of sacrum was absent, what could have been the answer? If one ala absent, yes, naloxone, correct answer. Yes, Rao, yes, Kitesh. Very good. Asghar Ali, very nice, wonderful. Rahul, Divya, Neha, Dushyant, Yashasvi, Avinash, very good. I'm so happy. All of you are marking correct answers. Sandeep, Vigneshwar, wonderful. Yogi, Pranav, Vishnu. Yeah. So I should remember the names also, no? Because I have to give chocolates. Yeah. Vijay, Basanti, Vishnu, Chelsea, Kiran, Murli, very nice, wonderful. So if one ala of sacrum absent, Nigle's pelvis. If both ala of sacrum absent, this is Robert's pelvis. Triradiate pelvis is seen in. These four options are four important chocolate questions. So Nigle pelvis, one ala of sacrum absent. Robert pelvis, both ala of sacrum absent. Triradiate pelvis, osteomalacia in adults. Reniform pelvis, or kidney-shaped pelvis or bean-shaped pelvis, severe rickets in children. I repeat these four questions once again. So kidney-shaped pelvis or reniform pelvis or bean-shaped pelvis is seen in severe rickets in children. Triradiate pelvis is seen in osteomalacia in adults. What is Nigle pelvis? If one ala of sacrum absent. What is Robert pelvis? If both ala of sacrum are absent. Wonderful. Let's move to another question. Don't be strongly mental, be mentally strong. What does it mean? The problem is I'm receiving multiple messages from a student. Few of them I'm not even able to read. सर याद नहीं हो रहा, सर समझ में नहीं आ रहा, पास हो पाएंगे या नहीं हो पाएंगे. सर ऐसा लगता है जैसे पढ़ा था पर अब याद नहीं आ रहा. बेटा जो पढ़ा था ना वो यहाँ पे रखा हुआ है. Everything is in our subconscious. Everything is in our subconscious mind and we will have a recall on examination hall. तो डरना नहीं बेटा. तो ये मत सोचो कि याद नहीं आ रहा या एग्जाम वाले दिन क्या होगा, याद आएगा या नहीं आएगा, या आप क्या पढ़ें, एग्जाम के 10 दिन बचे हैं मैं क्या पढ़ लूं, एग्जाम के 9 दिन बचे हैं पहले क्या पढ़ लूं, एग्जाम के 8 दिन पहले क्या पढ़ लूं. बेटा बहुत सारी चीजें बेटा रखी होती हैं और जैसे हर इंसान की शक्ल अलग है ना, वैसे हर इंसान थोड़ा थोड़ा अलग है. तो अपने को खुद पता है कि हम किस एरिया में वीक हैं इस टाइम. यार मेरे ड्रग्स भूल गया क्या, मुझे फार्मा पढ़नी पड़ेगी क्या, या मुझे थोड़ा माइक्रो देखना पड़ेगा क्या, या मैं थोड़ा सा भूल गया. कुछ वोलेटाइल सब्जेक्ट्स होते हैं, कुछ वोलेटाइल एरियाज होते हैं जो जल्दी जल्दी हम भूल जाते हैं, विच वी टेंड टू फॉरगेट. तो हमको क्या पढ़ना है, स्टेजिंग ऑफ कैंसर्स हैं, इमेजेस हैं. सो दिस डिपेंड्स ऑन अस, बट व्हाट आई वुड सजेस्ट यू फ्रॉम माई साइड, go through all the volatile areas, go through all the images, and you all know what are the high yield subjects. So don't miss out on high yield subjects. All of the following are included in the first stage of labor except. So all of the following are included in first stage of labor except. First stage is divided in latent phase and active phase. Latent phase is up to 5 centimeter and active phase begins beyond 5 centimeter, that is from 6 centimeter to 10 centimeter. So effacement of cervix occurs in first stage, latent phase. Dilatation of cervix mainly occurs in active stage. Crowning of fetal head, second stage. Descent of fetal head start occurring from the first stage. So what is happening here? Crowning of fetal head, it does not occur in first stage, it occurs in second stage. Clear? So let me show you, let me tell you quickly. Latent phase, what is happening mainly? Effacement. Active phase, what is happening mainly? Cervical dilatation. What is the rate of dilatation in primi? 1.2 centimeter per hour. Multi, 1.5 centimeter per hour. WHO says it should be at least 1 centimeter per hour. And descent of head, primi 1 centimeter per hour, multi 2 centimeter per hour. And what is the correct sequence of cardinal movements in second stage of labor? Let me show you what is the correct sequence of cardinal movements in second stage of labor. This question is frequently asked. Correct sequence: engagement, descent, flexion, then internal rotation. After internal rotation, crowning, and then extension. So let me repeat. What is engagement? When fetal head, presenting part, enters pelvic prim. Then descent flexion, then internal rotation. Internal rotation occurs at what level? Important question. Internal rotation occurs at the level of ischial spine. How much does occiput rotate during internal rotation? 90 degree or 2 by 8. After internal rotation, what is happening? After internal rotation, crowning. What is crowning? Crowning is permanent visualization of scalp hairs even when uterine contraction is over. What happens when uterus contracts? When uterus contracts, this fetal head comes out. And as soon as contraction recedes, this head goes inside. So crowning is permanent visualization of scalp hairs even when uterine contraction is over. Very important MCQ beta. What is recommended at the level of crowning? Modified Rittgen maneuver. What is modified Rittgen maneuver? We are pulling the chin, and we are pressing occiput. So we are facilitating extension because head encephalic is delivered by extension. Very important question. What is recommended at crowning by WHO? Modified Rittgen maneuver. Then after this extension occurs, after extension restitution. Restitution is untwisting of neck 45 degree. Then what is external rotation of head? Internal rotation of shoulders. When internal rotation of shoulders occurs, you can see passive movement of head outside due to internal rotation of shoulders inside. This is called external rotation. What is this called? External rotation. And then what is happening after external rotation? Anterior shoulder will be delivered, posterior shoulder delivered. Which injection is given at the delivery of anterior shoulder? Can anyone answer? Chocolate question. Question for the chocolate. Which injection is given at the delivery of anterior shoulder? This is called prophylactic drug of choice for postpartum hemorrhage. And what is the prophylactic drug of choice for PPH? Oxytocin 10 international units by intramuscular injection. Then trunk is delivered by lateral flexion like this. Then which cord clamping is done? Immediate or delayed? Normal cord clamping is delayed cord clamping between 1 to 3 minutes. Then baby is given to pediatrician and we are left with the cord. So which cord traction is done? Modified Trent Andrews technique, that is controlled cord traction. And it is given after we have seen signs of separation of placenta. Signs of separation of placenta, vaginal sign. Can anyone speak out? What is the vaginal sign? Yes, oxytocin, yes. What is the vaginal sign of separation of placenta? Very important question. Vaginal sign of separation of placenta, gush of blood through vagina. You can feel placenta in vagina and permanent lengthening of umbilical cord. What is abdominal sign of placental separation? Uterus become firm, globular and cricket ball like. So let's come back to our question. All of the following are included in the first stage of labor except. So crowning indicates second stage of labor. We don't need more time beta, we need more concentration in same time. 10 दिन बहुत है. 10 days are enough. We don't need 11 days today. We don't need 12 days today. We need more concentration in these 10 days. That's all. And what is the best way? What is the best way to improve concentration? We get distracted. हम हिम्मत हार जाते हैं. लगता है कि यार अब नहीं होगा. जब भी ऐसा विचार मन में आए कि अब नहीं होगा, मुझसे नहीं हो रहा, 5 मिनट के लिए या 10 मिनट के लिए हा करके हंसना शुरू कर दो. जब हम हंस रहे हैं ना, when we are laughing, what is happening, you know? अगर हंसना शुरू कर दिया, हम thoughtless हो जाते हैं. हमें कोई विचार नहीं आता. We become thoughtless. We are just laughing. Ha. We become thoughtless. And when you become thoughtless, you become relaxed. You become stress free. अगर अपने आप को stress free करना है, अगर अपने आप को relax करना है, तो thoughtless होना पड़ेगा. Thoughtless होने का सबसे अच्छा तरीका है हंसना शुरू कर दो. हंसते हुए मुझे दुखी होके बता दो. बहुत जोर जोर से हंसो. Ha. And feel sad now. Can you feel sad? No. हंस लो यार 5 मिनट, सारी चीजें खत्म हो जाएंगी और हमारी कंसंट्रेशन इंप्रूव हो जाएगी पढ़ने के लिए. चलो नेक्स्ट क्वेश्चन. A 32-year-old, her age is 32 years and she is multigravida. She is not priming, she is multi. Presented at 36 weeks of gestation. So how many weeks pregnancy? 36 weeks pregnancy. with breech presentation. So she is presenting at 36 weeks with breech presentation. All of the following are indications for cesarean section here except. So question is except. In which breech cesarean is not required? Stargazer breech, beta, we know. Stargazer breech means hyperextended head, as if it is looking at stars in the sky. So stargazer breech, cesarean section. Frank breech, assisted breech delivery can be tried. Footling breech, cesarean section. Entrapment of aftercoming head in term breech, cesarean section, Javanelli maneuver. So correct answer is B, Frank breech. Correct answer is B, Frank breech. Let me quickly tell you in 2 minutes breech and its delivery. In 2 minutes only, types of breech and its delivery. So breech is of two types, complete breech and incomplete breech. What is complete breech? If thighs are flexed and knee are also flexed. This is complete breech. What is the PV finding here? Buttocks, genitalia and feet. What is incomplete breech? Three types, frank, knee and footling. What is frank breech? If thighs are flexed and knee are extended, this is frank breech or extended breech. What is per vaginal exam finding? Buttocks and genitalia. What is knee breech? Thighs extended, knee flexed. What is PV finding? Knee. What is the footling breech? Thighs extended, knee also extended. What is PV finding? Footling, feet. And what is the most dangerous breech? Most dangerous breech is footling breech, because maximum risk of cord prolapse is in which breech? Maximum risk of cord prolapse is in footling breech. So most dangerous breech is footling breech and safest breech is frank breech or extended breech. What is the maneuver to deliver extended legs in breech? Pinard maneuver. For extended arms, Loveset maneuver. Best maneuver to deliver after coming head? Piper's forceps. In India, best one is Burn-Marshall method. Question number 12. A 27-year-old pregnant lady. Her age is 27 and she has a twin pregnancy. She goes in labor. She is in labor. Following the vaginal delivery of first twin, following the vaginal delivery of the first twin, she was taken to the operation theatre for internal podalic version. Following the delivery of the first twin, she was taken to the operation theatre for internal podalic version. All of the following statements are correct about this condition here except. So internal podalic version is done to deliver second twin in transverse lie. We all know this. And what's another name of internal podalic version? Another name of internal podalic version is breech extraction. So beta, don't confuse assisted breech delivery with breech extraction. Breech extraction means, what is breech extraction? Breech extraction means, or internal podalic version means, if second twin is in transverse lie. So we are going inside. How you can go inside? Because first fetus was just delivered. So cervix is completely dilated. And this is how internal podalic version is done. We go inside and then we take these, we grasp these podalic parts and we bring them down. This is why this is called which version? Internal podalic version. Internal podalic version. So this is done for second twin in transverse lie. It is done in operation theatre, general anesthesia. Anesthetic used is halothane because halothane provides good uterine relaxation. What is the complication of this procedure? Uterus may rupture. Complication, very important, uterine rupture. So breech extraction or internal podalic version is done to deliver second twin in transverse line. We go inside, we hold the podalic part and we bring them down. This is internal podalic version. What is external cephalic version, beta? Few words about external cephalic version. External cephalic version is tried in breech or in transfer. In breech, we do the ultrasound, we localize the head, and we can try to bring it down. In transverse, externally, we localize where the head is, we hold the head, and we bring it down. This is called external cephalic version. So external cephalic version is the management for breech. External cephalic version is the management for transverse if she is not in labor. Transverse, if she is in labor, only management is cesarean section. Fine. Don't confuse external cephalic version with internal podalic version. Internal podalic version is also called breech extraction, which is done to deliver second twin in transverse line. Fine. It is done to deliver second twin in transverse line. In transverse line. Mike. So I think some voice issue was there. Okay. So internal podalic version or breech extraction, those who couldn't hear because of this mic, now I am audible because mic just got slipped. This is why I might not be audible. Now you have mic. Fine. Yeah. Can you hear me now? Can you hear me now? I will repeat once again as you are asking. Internal podalic version or breech extraction is done to deliver second twin in transverse line. Very important question for our exam, beta. External cephalic version is done to manage transverse if not in labor and to manage breech. If transverse is in labor, only management is cesarean section. So anesthetic agent of choice is halothane, correct statement. If first twin was transverse, management would have been cesarean section, correct statement. What is the rule to manage twin pregnancy? Rule to manage twin pregnancy is if first fetus is non-cephalic, only management is cesarean section. I repeat, beta. If first fetus is breech or if first fetus is transverse, which is very rare, management is cesarean section. We can try vaginal delivery in twin pregnancy only if first fetus is cephalic. Fine. So we can try vaginal delivery in twin pregnancy only if first fetus is cephalic. If first fetus is non-cephalic, then only management would be cesarean section. Second twin might be in transverse lie. Second twin was in transverse lie. This is why it was done. Most common presentation in twins is first cephalic, second breech. This is incorrect statement. Can you tell me, beta, what is the most common presentation in twin? Chocolate question. Although very simple, chocolate question deserves chocolate also. What is the most common presentation in twin? Can you write here? What is the most common presentation in twin? Can anyone? Yeah, the answer is D. Yes, answer is D. That's clear. But I am asking you a different question now. What is the most common presentation in twin? This chocolate is nothing, yaar. You all are doctors. This is out of my love. This is out of my love and affection. What is the most common presentation in twin? Tell me. Both cephalic, very good. Pushpinder, again you rock. Pushpinder, again you rock. Kavita, Prema, now everyone has started answering. Everyone has started answering and all of you can collect chocolates from me. I have given you my phone number. Okay, so most common presentation in twins is both cephalic. So this is the incorrect statement. Next question. A 24-year-old lady. Her age is 24 years. Her age is 24 years. 24-year-old lady present with 16 weeks of amenorrhea. Present with 16 weeks of amenorrhea and bleeding per vagina. Okay. She says that she is 4 months pregnant and she is complaining of bleeding per vagina. She gives history of passage of few pieces. Okay, 4 months pregnant lady, complaining of bleeding per vagina, and she is saying, Doc Sahab, I have passed few pieces. On per abdominal examination, very good, Muhammad Salman, Basant, everyone is answering. Wonderful. I'm so happy all of you are so nicely prepared. Fine. On per abdominal examination, fundal height is less than period of amenorrhea. Fundal height is less than period of amenorrhea. Vaginal examination, internal os is open. So abdominal examination, fundal height is less than period of amenorrhea. Vaginal examination, internal os is open. What is most likely? Please answer the question. Please answer the question. Yeah, Firoz, very good. Yashasvi, very good. Mahesh, why B, yaar? Why B? Tell me. Khushbu, D. Umar, D. D is the correct answer. Very good. Very good. Dibima, D. Bhupesh Chawla, D. Rao Shab, D. Very good, wonderful. Let me explain you quickly. In 2 minutes, you will understand the concept of abortion. Let me explain you. If she has passed pieces and still some pieces are retained inside, this is called incomplete abortion. Because she has passed pieces, beta, this is why fundal height is less than period of amenorrhea. And of course, because she has passed pieces, internal os is open. This is incomplete abortion. Threatened abortion, if it is threatened abortion, listen to me very carefully. Examination concepts, examination question. If it is a case of threatened abortion, fundal height will be equal to period of amenorrhea because she has not passed anything, that's one. Vaginal examination, internal os will be closed. Internal os will be closed, fundal height will be equal to period of amenorrhea. Clear? And there was no such line like she has passed some pieces. So threatened abortion is gone. Missed abortion, internal os is closed. She is asymptomatic. This is why it is called missed abortion. Few patients may complain of dirty brownish discharge that is due to thromboplastin, that we know. So missed abortion is gone. Inevitable abortion, examiner will not write this line that she gives history of passage of few pieces. Inevitable abortion, unavoidable abortion, internal os will be open, but she has not passed anything. This is the only difference between inevitable abortion and incomplete abortion. If there is history of expulsion of products of conception, incomplete abortion. If no history of expulsion of products of conception, inevitable abortion. Very simple way to crack these types of questions. Another question. A 30-year-old lady. She is a 30-year-old lady with heart disease. Okay. She is a lady with heart disease, presents in labor, obstetrician planned for a ventouse delivery. We use ventouse in heart disease to cut short second stage of labor. To cut short the second stage of labor. All of the following statements are correct in this condition here. Again, there is a word except. So what we are doing, we are conducting delivery in a lady with heart disease. Okay. And obstetrician has planned a ventouse. Option A. Ventouse is placed on the sagittal suture 3 cm anterior to posterior fontanelle. Yes, ventouse is placed here. Let me show you something about ventouse. Let me show you something about ventouse. Now, this is the sagittal suture. This is the sagittal suture. And this is how this ventouse is placed. This ventouse is placed on sagittal suture. And where is it placed? This is the sagittal suture. Ventouse is placed on sagittal suture 3 cm anterior to posterior fontanelle. And then this ventouse is connected to suction machine. Initial suction pressure 0.2 kg per square centimeter. Optimum suction pressure 0.8 kg per square centimeter. And it is increased by 0.1 per minute. So total 6 minutes are taken to attain optimum suction pressure. Let's come back to our question. Heart disease, vacuum application. It is placed on the sagittal suture 3 cm anterior to posterior fontanelle. Correct statement. Optimum pressure required is 0.8 kg per centimeter square. Correct statement. Initial suction pressure 0.2. Optimum suction pressure 0.8. And how it is increased? 0.1 per minute. So total how many minutes are required? 6 minutes are required to attain optimum suction pressure. Injection diuretic should be given immediately after delivery in heart disease. Correct statement, beta. Why it is correct statement? Injection diuretic should be given immediately after delivery because maximum cardiac output in heart disease is immediately after delivery. Overall also, otherwise also. And she is having heart disease, so we want to reduce plasma volume. This is why if she is having heart disease, immediately after delivery, we prefer to give diuretic injection because we all know cardiac output overall is maximum immediately after delivery. Option 4, it is even better in fetal distress. No, beta. Vacuum is contraindicated in fetal distress. This ventouse application is contraindicated in fetal distress? Can anyone tell me? Chocolate question. Why ventouse application is contraindicated in fetal distress? Why ventouse application is contraindicated in fetal distress? Can anyone tell me? Why? Why ventouse application is contraindicated in fetal distress? Can anyone tell me why ventouse application is contraindicated in fetal distress? Fetal distress, we can't wait for 6 minutes. Priya Mishra, this chocolate is for you. Priya Mishra, fetal distress, we can't wait for 6 minutes. This chocolate is for you. Very good. You can take chocolate. Wonderful. I'm so happy. So we need to choose the incorrect statement because the question says accept. So the answer is incorrect statement. Vacuum is never used in fetal distress. Another question. A preeclamptic patient at 31 weeks of gestation came for a regular antenatal checkup. At present, her BP is 136 by 100 and proteinuria is 600 milligram per 24 hours. So blood pressure is 136 by 100 and proteinuria is 600 milligram per 24 hours. What is best management for her? Please reply. Please reply. What is best management for her? Please reply. I am waiting for your answers. Best management for her. So what is this preeclampsia? First of all, we have to decide. Examiner has clearly written she is a preeclamptic patient. So which preeclampsia is this? Because management of preeclampsia depends on whether this is a case of mild preeclampsia, whether this is a case of severe preeclampsia, whether this is a case of HELP syndrome, whether this is a case of eclampsia. So whenever BP is high, proteinuria is more, we have to categorize 4 things. Whether this is mild preeclampsia, whether this is severe preeclampsia, whether this is a case of HELP syndrome, or this is a case of eclampsia. Tell me. Mild preeclampsia, wonderful, very good, serotonin, very good. This is mild preeclampsia. So Amandeep says, wait till 37 weeks and induce labor at 37, you are perfect. Everyone is answering A because we all know better. And let me give you the concept here. Let me give you the concept. Important questions for 4th June exam. Management of mild preeclampsia, monitor till 37 weeks and induce labor at 37. Question number 1, done. Question number 2, management of severe preeclampsia. Labetalol, drug of choice to treat preeclampsia, labetalol. Then we have to give steroids. Continue pregnancy till what? This is the MCQ beta, 37 or 34. In mild preeclampsia, we continue till 37. In severe preeclampsia, we continue till 34 and we induce labor at 34. So mild preeclampsia, induction of labor at 37 weeks. Severe preeclampsia, induction of labor at 34 weeks. No drug treatment is given for mild preeclampsia because there is no end organ damage in mild preeclampsia. End organ damage occurs only in severe preeclampsia. So drug treatment is required only in severe preeclampsia. So wait till 37 and induce labor at 37. That's the correct answer. Perform LSCS at 37. See whether this is preeclampsia, whether this is eclampsia, which mode of delivery is preferred? Vaginal. Why we don't want to go for cesarean section, beta? She is already in distress. Why do you want to put her in unnecessary complications of anesthesia? So which mode of delivery is preferred? Vaginal. So LSCS is out of question. Induction of labor at 34 weeks. Induction of labor at 34 weeks would have been the answer to which question? If BP was more than 160 systolic and more than 110 diastolic, because severe preeclampsia is if systolic BP is 160 or above and diastolic BP is 110 or above. If in this question blood pressure systolic was more than 160, diastolic was more than 110, answer to this question would have been induction of labor at 34 weeks because that was severe preeclampsia. But this question is about mild preeclampsia, and in mild preeclampsia, induction of labor is done at 37 weeks. Quickly crack those 2 other questions. What is the management for HELP syndrome? Management for HELP syndrome, immediate induction of labor. Eclampsia, drug of choice to prevent convulsion, magnesium sulfate. Drug of choice to treat convulsion, magnesium sulfate. If a patient with seizures enter your chamber, what is the first step? Maintain her airway. This is what examiner want to know from you. If a patient with convulsions enter your OPD, what is the first step? First step in the management is maintain her airway. Let's quickly revise those single liners. Drug of choice to treat preeclampsia, labetalol. Drug of choice to treat emergency hypertension in pregnancy, IV labetalol. If not in option, IV hydralazine. Drug of choice to treat chronic hypertension in pregnancy, labetalol. If labetalol not in option, alpha methyl dopa, as happened in last FMGE exam. Drug of choice to prevent PIH, aspirin. But please don't confuse. Drug of choice to treat PIH, labetalol. Drug of choice to prevent PIH, aspirin. Drug of choice for refractory hypertension in pregnancy, sodium nitroprusside. Drug of choice for status epilepticus, thiopenton sodium. I quickly repeat these single liners which are very important. Drug of choice to treat preeclampsia, labetalol. Drug of choice to treat emergency hypertension in pregnancy, IV labetalol. If not in option, IV hydralazine. Drug of choice to prevent PIH, aspirin. Drug of choice to treat emergency hypertension in pregnancy, sodium nitroprusside. Drug of choice to treat status epilepticus, thiopenton sodium. Drug of choice to prevent convulsion, magnesium sulfate. Drug of choice to treat convulsion, magnesium sulfate. So answer to this question is this. Wait till 37 weeks because this is mild. If it is severe, wait till 34. Let's move to another question. A 30-year-old lady. 30-year-old lady. She is a 30-year-old lady. She presents with amenorrhea for last 8 months. Okay. Amenorrhea for last 8 months. She was normally menstruating before. Now she is amenorrheic for last 8 months and she was normally menstruating before. Her urine pregnancy test is negative. Okay. UPT is negative. She is not pregnant. Fine. TSH and prolactin are within normal limits. Okay, fine. Progesterone. This is progesterone. This word is progesterone. Progesterone challenge test is negative. Okay, you gave her progesterone and she didn't respond. She didn't have any bleeding after progesterone challenge test. Then combined estrogen progesterone challenge test is also negative. She didn't respond to progesterone alone, so a combination of estrogen and progesterone was given, which is called combined estrogen progesterone challenge test. That is also negative. She didn't respond even to that. What is the likely site of defect in this condition? Please tell me the answer quickly, everyone. Vanta B. Endometrium. Wonderful, wonderful. Everyone is answering B. Wonderful answer. If combined estrogen progesterone challenge test is negative, defect is lying at the level of endometrium. And the most common defect here is endometrial tuberculosis, which may result in Asherman syndrome. So instead of endometrial word, endometrial TB could have been written here, or Asherman syndrome could have been written here. Fine, very good, wonderful. I am so happy. And in 1 minute, I want to give you the concept of diagnostic protocol of secondary amenorrhea. In just 1 minute, I will give you the concept. What is the concept? If a patient presents with, listen to me, I am bombarding MCQs now, bombarding examination questions now. First question, a patient with secondary amenorrhea presents to you, what is the next step? Tell me the answer. Can anyone answer me? A patient with secondary amenorrhea presents to your OPD, what is the next step? What is the first thing you will do? What is the most common cause of secondary amenorrhea? What is the most common cause of secondary amenorrhea? Pregnancy. So if a lady enters your chamber with complaint of secondary amenorrhea, what is the first thing you will do? You will conduct a UPT, urine pregnancy test. Wonderful, wonderful. So first step is urine pregnancy test, because most common cause of secondary amenorrhea is pregnancy. Second question, a lady presents in your chamber with secondary amenorrhea, her urine pregnancy test is negative. What is the next step? Examination questions, beta. Urine pregnancy test is negative. What is the next step? Please tell me. UPT negative, next step. Get done TSH prolactin. Third question, UPT negative, TSH prolactin normal. What is the next step? Progesterone challenge test. Fifth question, lady presents with secondary amenorrhea. UPT negative, TSH prolactin normal. Progesterone challenge test negative. What is the next step? Combined estrogen progesterone challenge test. Sixth question. Lady presented with secondary amenorrhea, UPT negative, TSH prolactin normal, but progesterone challenge test is positive. Progesterone challenge test is positive. Progesterone challenge test is positive. What comes to your mind? If progesterone challenge test is positive, what is the cause of her secondary amenorrhea? Cause of her secondary amenorrhea, if progesterone challenge test is positive, is anovulation. And most common cause of anovulation today in this world from North Pole to South Pole is polycystic ovarian syndrome. So beta, examiner can twist this question. A lady presents with secondary amenorrhea, UPT negative, TSH prolactin normal, progesterone challenge test positive, what is most likely? In option, examiner can put the word anovulation. Instead of anovulation, polycystic ovarian syndrome can also be there, because most common cause of anovulation today is PCOS. Clear? Next question. If progesterone challenge test negative, what is the next step? Combined estrogen progesterone challenge test. If it is negative, endometrium or Asherman syndrome. If it is positive, defect could be either ovarian or hypothalamic or pituitary defect. So if combined estrogen progesterone challenge test is positive, if this question was framed like this, that combined estrogen progesterone challenge test is positive, what is the next step? Can anyone tell me? Can anyone tell me if combined estrogen progesterone challenge test is positive? What is the next step? Can anyone? A chocolate question. Chocolate question. Person answering deserves the chocolate. If combined estrogen progesterone challenge test is positive, what is the next step? What is the next thing you would like to do? Very good. Vanta FSH. This chocolate is for you. You answered first. You answered first. All of you who have answered FSH deserves chocolate. Many chocolates. Don't worry. Many chocolates. Many chocolates. So all of you who are answering correct deserve chocolate. Fine. Okay. So defect is lying at endometrium here. If combined estrogen progesterone challenge test is positive, next step is get done her FSH. Next question. If FSH is high, where the defect is lying? If FSH is high, where the defect is lying? Where is the defect? If FSH is high, where is the defect? Tell me please, if FSH is high, where is the defect? Ovarian disorder, because ovaries secrete estrogen. If ovary is damaged, estrogen will fall and paradoxically FSH will increase. And if FSH is low, hypothalamic defect or pituitary defect. So if FSH is low, get done MRI or give injection GnRH. After giving injection GnRH, if FSH increase, where is the defect? Hypothalamic defect. Let's come to question. लिख दे खून से अपनी कामयाबी की कहानी, लिख दे खून से अपनी कामयाबी की कहानी और बोल इस किस्मत को है दम तो मिटा कर दिखा. इन 10 दिन के अंदर, इन 10 दिनों में लिख दे खून से अपनी कामयाबी की कहानी. सुबह से शाम पूरी शिद्दत के साथ रिवाइज करना है और बोल दे अपनी किस्मत को. अगर किसी पंडित ने कह दिया, किसी पंडित को हाथ दिखाया था, किसी पंडित को जन्म पत्री दिखाई थी और पंडित ने पता क्या कह दिया, ओ पता नहीं होगा कि नहीं होगा, उस पंडित को बोल देना है दम तो मिटा के दिखा. मैं तो पढ़ूंगा, पूरी शिद्दत से पढ़ूंगा, लेजर फोकस के साथ पढ़ूंगा. कम ऑन. नेक्स्ट क्वेश्चन. A 35-year-old nulliparous lady. Her age is 35 years. She is a nulliparous lady. Presents with pelvic pain. Okay. Her complaint is pelvic pain. And a mass descending per vagina. Okay. She is complaining of pelvic pain and a mass descending per vagina. Something is coming out of vagina, which increases in size on coughing. If she coughs, so abdominal pressure is increased, so this is prolapse. Decubitus ulcers are seen on prolapsing mass. So decubitus ulcers develop in prolapse, and what is the reason for decubitus ulcer? Chocolate question, important chocolate question of our exam. What is the cause of decubitus ulcer? Venous congestion. Venous congestion. Fine. So decubitus ulcers are seen on prolapsing mass. What would be most appropriate management for this condition? Tell me what is the most appropriate management. Management of prolapse depends on what, beta? Parity. Management of prolapse depends on parity. She is not a multiparous lady, she is a nulliparous lady, and nulliparous lady wants future child bearing. So in nulliparous lady, no destructive procedure can be done. Fothergill operation is done in a multiparous lady. So fothergill is gone. Ward Mayo vaginal hysterectomy, multiparous lady. How can you take out her uterus? She is nulliparous. She wants future child bearing. Cervicopexy is another name for abdominal sling operation. So if she is a nulliparous lady, abdominal sling operation is done. And another name of abdominal sling operation is cervicopexy. So cervicopexy is the correct answer. Everyone is writing C. I'm so happy. Everyone is writing C, cervicopexy. So nulliparous abdominal sling operation or cervicopexy. Which cervicopexy is best? Virkud cervicopexy. Virkud cervicopexy is a combination of Purandre and Shirotkar. Purandre, Marceline tape is attached to rectus sheath, and Shirotkar, it is attached to sacral promontory. And what is done in Virkud? We perform Purandre on left side and Shirotkar on right side, because Shirotkar has multiple complications on left side. So cervicopexy is done in nulliparous. Anterior colporrhaphy is treatment of cystosis. It is treatment of vaginal wall prolapse, not for uterine or cervical prolapse. So cervicopexy is the correct answer. वक्त मत लगाओ तय करने में कि क्या करना है, वरना वक्त तय कर देगा कि किसका क्या करना है। 10 दिन है, सोचना नहीं है, केवल रिवाइज करना है, केवल पढ़ना है, फालतू किसी बात पर ध्यान मत देना। आई रिपीट, वक्त मत लगाओ तय करने में कि क्या करना है, वरना वक्त तय कर देगा किसका क्या करना है। थोड़े से हार्श वर्ड है, लेकिन 10 दिन पहले यूज करना चाहता हूं, जिससे इन 10 दिन का पूरा यूटिलाइजेशन कर लो। Another question. A 32-year-old lady presents with continuous dribbling of urine through vagina. She doesn't feel desire to go for micturition. On her own. She gives a history of unattended vaginal delivery following a difficult and prolonged labor 4 months back. What is the most likely diagnosis? So her age is 32, continuous dribbling of urine, and she doesn't feel desire. She doesn't feel that. Thank you, Bhajan. Thank you. Thank you so much, everyone. Thank you so much for encouraging me also. Fine. So she doesn't feel desire to go for micturition. So what has happened to her? Which type of fistula is this? C. Everyone is C, vesicovaginal fistula. Vesicovaginal fistula, she does not feel desire to go for micturition on her own. Uretrovaginal fistula, she feels desire to go for micturition on her own. Urethrovaginal fistula, dribbling of urine only at the time of micturition. Uretrovaginal, she feels desire. Vesicouterine leads to hematuria at the time of menstruation. In this question, no hematuria written at the time of menstruation, so it is not vesicouterine. In this question, she does not feel desire to go for micturition, so it is not uretrovaginal. Urethrovaginal, dribbling of urine only at the time of micturition. And here, which dribbling? Continuous dribbling. So all three are gone, and we are left with the best and correct answer, vesicovaginal fistula. What is the most common cause of vesicovaginal fistula in developing countries like India? Obstructed labor. And she had an unattended delivery. This was an obstructed labor. Unattended vaginal delivery following a difficult and prolonged labor. And most common cause of vesicovaginal fistula in developing countries like India is obstructed labor. वो पल भी आएगा जिसकी ख्वाहिश है आपको, वक्त पर रखो भरोसा, रत पर एतबार रखो. वो पल जिस दिन हम पास होंगे, हमारे हाथ में नेशनल बोर्ड ऑफ एग्जामिनेशन का सर्टिफिकेट होगा. वी विल हैव सर्टिफिकेट फ्रॉम एनबीई. वो वक्त बस आने वाला है. इन 10 दिन का पूरी तरह से उपयोग कर लो. यूटिलाइज दीज 10 days. and you will get that moment when you will be going to NB office to collect your certificate. Fine. ठीक है, चिंता नहीं करना, डरना नहीं है, वक्त पर रखो भरोसा और रब पर एतबार रखो. That's all. सब कुछ ठीक होगा. Next question. A 29-year-old multiparous lady. Her age is 29 years. She presents with menorrhagia. Her complaint is menorrhagia. And this menorrhagia is since last 6 months. On ultrasound examination, a 7 by 6 centimeter intramural fibroid was seen. What is the most appropriate management for her? So management of fibroid depends on symptoms. If she is asymptomatic, no symptom, follow up. If symptoms are present, treatment is done. And primary treatment for fibroid is surgical treatment. If she is multiparous, total abdominal hysterectomy. If she is nulliparous, myomectomy. So she is a nulliparous lady and she is having a symptom. She is not asymptomatic. In management question of fibroid, if no symptom is written, it is follow-up. Answer is observation or follow-up if size of fibroid is less than 10 centimeter. If symptom is given, you have to treat the patient. And how you treat the patient, then it depends on parity. Nulliparous, myomectomy. Multiparous, TH, total abdominal hysterectomy. So she is a nulliparous lady. What is the most appropriate management? She is having a symptom, so no observation here. Observation and follow-up are done if no symptom is written. Asymptomatic and size of fibroid less than 10 centimeter. Management is observation and follow-up. So observation and follow-up is gone. Ultrasound, observation and follow-up by ultrasound. We do observation and follow-up by ultrasound. We repeat ultrasound after 3 or 6 months. Total abdominal hysterectomy, this is also gone. Total abdominal hysterectomy would have been the answer if multiparous was written here. And here nulliparous is written. Because nulliparous is written here, so answer is myomectomy. If multiparous was written here, answer would have been total abdominal hysterectomy. Continuous GnRH. Continuous GnRH is given to nulliparous lady if she is unwilling for surgery or if there is any contraindication for surgery. Then we give drug treatment with continuous GnRH or mifepristone or ulipristal or letrozole or danazole or gastrinol. And to control local bleeding, tranexamic acid is given. So continuous GnRH is gone. There is no contraindication for surgery. Nothing severe hypertension, severe diabetes or contraindication for surgery or unwilling for surgery. If those words would have been given in this question, then answer would have been continuous GnRH. So it's ruled out. Myomectomy is the correct answer because she has symptom and she is nulliparous. Fine. मैं इतनी दूर आया हूं यहां रहने के लिए नहीं और आगे जाने के लिए. ये लाइन बड़े दिल से बनाई मैंने because I have seen many foreign medical graduates. You go and live in adverse circumstances, even at minus 25, minus 30 degrees Celsius temperature. Many a times you miss your lunch, many a times you miss your meals. You are living away from your parents. You are living in so much hardships. तो बस इतना याद रखना यार, जब इतना झेल लिया, जब इतना बर्दाश्त कर लिया, तो बस ये लाइन याद रख लो. मैं इतनी दूर आया हूं यहां रुकने के लिए नहीं, यहां रहने के लिए नहीं और आगे जाने के लिए. केवल 10 दिन की बात है. 10 दिन में हम बहुत आगे निकल जाएंगे, बहुत आगे चले जाएंगे. बस थोड़ा सा और, बस 10 दिन और, केवल 10 दिन और. कम ऑन, नेक्स्ट क्वेश्चन. A 30-year-old lady. Her age is 30 years. She presents to your OPD with complaints of dysmenorrhea. Okay. Her age is 30 and she complains of dysmenorrhea and dyspareunia. Okay. Dysmenorrhea, pain at the time of menstruation. Dyspareunia, pain at the time of intercourse. On pervaginal examination, tender nodules in the posterior fornix were found. Tender nodules in the posterior fornix. As soon as you read this line, tender nodules in the posterior fornix, what comes to your mind? What is this field called as? What is this field called as? This is cobblestone field. Cobblestone field. Uterus is fixed retroverted, which happens in endometriosis because of sagging of uterosacral ligament. Because uterosacral ligament prevents retroversion of uterus. Chocolate question. Which ligament prevents retroversion of uterus? Uterosacral. Which ligament maintains anteverted position of uterus? Round ligament of uterus. Because uterosacral ligaments sag in endometriosis. Because endometriotic deposits fall on this ligament. So uterus becomes retroverted. Fixed retroverted uterus. So this is clearly indicating what condition? Endometriosis. Tender nodules in posterior fornix, cobblestone field, fixed retroverted uterus, endometriosis. Which of the following is the gold standard investigation to confirm the likely diagnosis? Now, examiner has not asked here what is this condition. Examiner is not asking what is this. This is endometriosis. How we conclude it? By cobblestone field, tender nodules in the posterior fornix, and uterus is fixed retroverted. Now, examiner is asking, examiner is clear that you all know what you are dealing about, what you are talking about. We are talking about endometriosis. So what is the gold standard investigation to confirm the likely diagnosis? Gold standard to diagnose endometriosis is histopathological examination. Fine. So first of all, we do per vaginal examination. What is PV finding in endometriosis? Fixed retroverted uterus and cobblestone field. Then we do ultrasound. Ultrasound finding in endometriosis, ovarian cyst with which appearance? Ground glass appearance. Then we move to laparoscopy, which is investigation of choice. Laparoscopy finding in endometriosis, chocolate cyst. Then bluish-black deposits in peritoneum, early lesions, tiny petechiae-like, late lesions, gunshot or powder burn appearance. Then we see fibrous bands or adhesion. But gold standard, investigation of choice in endometriosis is laparoscopy. But gold standard to diagnose endometriosis is histopathological examination of these deposits. Gold standard to diagnose PID. Everyone, come on. Gold standard. So the answer to this question is histopathology. Let me ask you a few other questions. Chocolate question. Gold standard investigation for PID. Gold standard investigation for PID. Come on, everyone. Let me see. Yeah, please. Gold standard investigation. Gold standard investigation. I think there is a, Gold standard is HP. Show it. Yes, you are right. For endometriosis, yes, we are clear. For endometriosis, this is histopathological examination. But gold standard, very good. Very good. Pushpinder, Himanshu, Ishan, Hema, Ajay, Devgan, Chaudhary, Bharat, Doki, Serotonin, Priya Mishra. Fine. Laparoscopy. Answer to this question is histopathological examination. Answer to this question is histopathological examination. But gold standard investigation to diagnose PID is laparoscopy. It is laparoscopy. Wonderful. Gold standard investigation for ectopic pregnancy. Please tell me. What is the gold standard investigation for ectopic pregnancy? Chocolate question. Will give us solid 1 mark in exam. Gold standard investigation for ectopic pregnancy, laparoscopy. Gold standard investigation for PID, laparoscopy. Gold standard for endometriosis, histopathological examination. Gold standard for adenomyosis, hysteroscopic curettage. Hysteroscopic curettage. Let's move to another question. A 25-year-old lady, her age is 25 years, with history of intercourse with multiple partners. So she is a 25-year-old lady with history of intercourse with multiple partners, complained of lower abdominal pain. What she is complaining of? She is complaining of lower abdominal pain and fever for 9 months. Lower abdominal pain and fever for 9 months. She did not complete the course of antibiotics. Okay. She was prescribed antibiotics, but she did not complete the course of antibiotics, which were prescribed by gynecologists. Following this, her infection failed to resolve. तो दवाई नहीं खाएगी तो ठीक कैसे होगा? Following this, her infection failed to resolve, and she developed a tubo-ovarian mass, which was diagnosed by ultrasound. Okay. All of the following can be ultrasound findings in this condition except. So what you are dealing with, first of all, let's conclude the question. What is this question? What you are dealing with? What is this question? This is the case of PID. Yes, very good, wonderful. Chaudhary Bharat, PID, very good. This is the case of PID. Most common risk factor for PID, intercourse with multiple partners. See how many clues are given. Most common risk factor for PID, history of intercourse with multiple partners, that clue is given. Most common symptom of PID, lower abdominal pain, second clue is given. So 2 clue for PID, most common symptom, lower abdominal pain given. Most common risk factor for PID, history of intercourse with multiple partners given. She was prescribed antibiotics, she didn't take. So this acute PID converted to chronic PID. Okay, now examiner is asking what should be the ultrasound findings for this condition. So chronic PID ultrasound findings we know, bead on string sign, cogwheel sign, waist sign, hydrosalping. But ground glass appearance is seen in. 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 Tell me. Ground glass appearance is seen in endometriosis. Ground glass appearance is seen in endometriosis. Bead on string sign, PID. Cogwheel sign, PID. Hydrosalpings, PID. Ground glass appearance, endometriosis. Let me show you these ultrasound appearances. Let me show you these ultrasound appearances in PID. Just have a look, just go through these ultrasound appearances. This is waist sign. What is this sign? This is the waist sign. Waist sign. This is waist sign. Waist sign in PID, you can see there's a narrowing here. There is a narrowing here like this. This is called waist sign. This waist sign indicates chronic PID. This is the waist sign. Let me show you other ultrasound findings in chronic PID. Other ultrasound findings in chronic PID, just have a look. This is the hydrosalping. You can see this fallopian tube, this fallopian tube. This is hydrosalping. This is elongated and dilated fallopian tube. What is this? This is hydrosalpings. So waist sign is a feature of chronic PID. Hydrosalpings is a feature of chronic PID. Let me show you other sign of chronic PID, that is bead on string sign and cogwheel sign. This is the bead on string sign. Bead on string sign. This is bead on string sign. As you can see, these fibrous bands, they have started developing in fallopian tube. What is this sign? This is bead on string sign. And when these fibrous bands become large, this is called cogwheel sign. Now I will show you cogwheel sign. Cogwheel sign in chronic PID like spokes of a wheel. You can see it beautifully. This is a cogwheel sign. This is a cogwheel sign. You can see this fibrous band protruding inside fallopian tube lumen. Protruding inside fallopian tube lumen. This is called cogwheel sign. So these are various ultrasound signs which are seen in chronic PID. Come on. So ground glass appearance, let me show you. That is the ultrasound feature for endometriosis. Let me quickly revise that ground glass appearance. This is a feature of endometriosis. This is ground glass appearance, and this ground glass appearance of ovarian cyst is seen in endometriosis. So this is a feature of endometriosis. Ground glass appearance. This ovarian cyst is filled homogeneously with low or medium level internal echo. So this is endometriosis, ground glass appearance. Let's move to another question. A 22-year-old lady, her age is 32 years. She is a 32-year-old lady who has been trying to conceive for the past 18 months. She is trying to conceive for the past 18 months. She underwent hysterosalpingography, that is HSG, hysterosalpingography investigation. The findings are given below. What is your interpretation? So this is the finding. This is the HSG image which is given here. And what is this HSG image? This is the hysterosalpingography investigation where we instill a radio opaque dye And you can see this is the uterus. And this radio-opaque dye is filling uterus. But this radio-opaque dye is not going beyond cornual ends on either side. So what is this condition? Please try to focus on this condition. This radio-opaque dye is limited to uterus, but it is not entering fallopian tube. So there is a bilateral cornual block. What is this block? Can you answer? What is this block? This is a bilateral cornual block. Everyone is answering D. I am so happy. I am so happy everyone is answering D. This is the case of bilateral cornual block. These HSG images are very important. Let me show you few other HSG images after cracking this question. So this is the case of bilateral cornual block. This is a normal hysterosalpingogram. No, this is the wrong answer. HSG showing septate uterus. No, I will show you a septate uterus. HSG showing a bicornuate uterus. No, I will show you a bicornuate uterus. HSG showing a bilateral cornual block. So this is a clear example of HSG showing a bilateral cornual block. Let me show you these few HSG images which may be asked on 4th of June. This is why I am showing you all these. So everyone, please start answering these questions. What is this image? Can anyone answer what is this HSG? What is this hysterosalpingography? And I will give you a clue how to diagnose this hysterosalpingography image. You can see there are two Leach-Wilkinson cannula. Radio-opaque dye is instilled via Leach-Wilkinson cannula. So there are two Leach-Wilkinson cannula and you can see two uterus. This is a case of double uterus. What is this case? This is a case of double uterus. Double uterus is also called uterine didelphys. So this is the case of double uterus, uterine didelphys. Please don't mistake it with bicornuate in exam. It is not a bicornuate uterus. Uterine didelphys or double uterus is the only condition in which there are two vagina. How many vagina are seen in uterine didelphys? Two vagina. Because there are two vagina, we need two Leach-Wilkinson cannula to instill radio-opaque dye. And you can see beautifully in this hysterosalpingography film, how many Leach-Wilkinson cannula are shown here? Two. So double uterus, as soon as you see two Leach-Wilkinson cannula, this is the case of double uterus or uterine didelphys. Let me show you a bicornuate and septate. Sometimes it becomes difficult to differentiate bicornuate and septate. I will give you a clue. This is a bicornuate uterus. Have a look. How many vagina are seen here? How many vagina are seen here? Only one vagina. Only one vagina. In previous film, there were two vagina. There were two Leach-Wilkinson cannula. So that was uterine didelphys, that was double uterus. This is single vagina and upper part of Mullerian duct is not fused. It is separate. So this is the case of bicornuate uterus. What is this? This is the case of which uterus? This is the case of bicornuate uterus. Other clues, which are higher level questions, how much is the distance between two horns in bicornuate? This distance has to be more than 4 centimeters. This angle is an obtuse angle. This angle is an obtuse angle. It is somewhere in the range of 100, 110 degrees. Fine, this is the case of bicornuate uterus. How to differentiate bicornuate with a septate uterus? Let me show you a septate uterus as well. This is the case of septate uterus. Now you can beautifully differentiate bicornuate with the septate. Can you see the distance? How many vagina first of all? How many Leach-Wilkinson cannula? One. So this is not double uterus, this is not didelphys. See the distance between two horns. It has to be less than 4 centimeters. And if it is more than 4 centimeters, that is bicornuate. So they are close to each other. Two horns of uterus, they are close to each other in septate uterus, while they are far apart in bicornuate uterus. Fine? So this is the case of septate uterus. And why you see this filling defect in the center? Why radio-opaque dye is not entering this place? Because of a septum in uterus here. This is why we see a filling defect here. So this is how we can clearly differentiate between a bicornuate uterus and a septate uterus. Let me show you a unicornuate uterus also. Unicornuate uterus. Unicornuate uterus, only one Mullerian duct has developed. Because only one Mullerian duct has developed, you can see only 50% of uterus is developed. Only on this side. only 50% of uterus, because a normal uterus develops by fusion of two Mullerian ducts. And unicornuate uterus or penis-shaped uterus or banana-shaped uterus develops if only one Mullerian duct develops embryologically. So this is the case of unicornuate uterus. How many fallopian tubes are associated with unicornuate? 1. How many vagina are seen in uterine diidal phase? 2. Come on. So we have seen all these images of all these malformations. Wonderful. Let's move to next question. All of you are answering wonderfully. Very good. I'm so happy. 10 days before FMGE exam, Miss Next Telegram series of expected questions is also following. We have been posting questions of multiple subjects on Miss Next Telegram group for a long time. In these 10 days, tomorrow onwards, in these next 10 days, I am posting all the questions at 9 p.m. every day. So Miss Next Telegram group also, you will see important questions from multiple subjects till 3rd of June. So anyone who finds difficulty in joining the Telegram group can telegram me or can text me on my number 7042109992. Fine. Next question. A 32-year-old lady. Her age is 32 years and she is complaining of, she has been diagnosed with polycystic ovarian syndrome. Is eager to conceive. She is a case of PCOS. She is eager to conceive. She has been diagnosed with infertility due to anovulation. We know. Since she is having polycystic ovarian syndrome, and most common cause of anovulation today is polycystic ovarian syndrome. All of the following statements are correct here, except. All of the following statements are correct here, except. Drug of choice for her is letrozole. How many agree with me? Come on. How many agree with me? How many agree with me? Tell me. Drug of choice for her is letrozole. Polycystic ovarian syndrome if she wants to conceive. Drug of choice to treat infertility in polycystic ovarian syndrome is letrozole. Correct statement. Question is except, so we need to choose incorrect statement. This is the correct statement, very important chocolate single liner question for our exam. Drug of choice to treat infertility in polycystic ovarian syndrome, letrozole. Correct. Most common diagnostic method for anovulation is by serial ultrasonography. Correct statement. Most common is by serial ultrasound. Best is estimation of serum progesterone. And to predict ovulation, LH kits. These three questions are different. Best method to diagnose anovulation, serum progesterone estimation. Most commonly used method, serial ultrasound. Prediction of ovulation is by use of LH kits. Drug of choice to treat hirsutism in PCOS is oral combined pill. Correct statement. And these three questions are very important chocolate questions for our exam. I'm repeating. I'm expecting something on 4th of June from these three lines. Drug of choice to treat infertility in PCOS, letrozole. Most common diagnostic method for anovulation, serial ultrasound. And best method, serum progesterone to predict LH kits. Drug of choice to treat hirsutism in PCOS, oral combined pill. Correct statement. Best management for her is in vitro fertilization. In vitro fertilization is best management to treat tubal block. IVF is best to treat tubal block, not for anovulation. Since we have to choose the incorrect statement, answer is D. Answer is D. हिम्मत नहीं हारना बस. जंगल का राजा कौन है? छोटी सी बात, 1 minute में. Who is the king of forest? जंगल का राजा कौन है? शेर. Election हुआ था क्या? Was any election conducted in the forest and lion was declared as the king of forest, emperor of forest? Who said, lion, that you are the king of forest? Was any election conducted in the forest? No. कोई चुनाव नहीं हुआ था जंगल में. कभी कोई चुनाव नहीं हुआ था जंगल में. जंगल का राजा शेर है क्योंकि शेर मानता है कि मैं जंगल का राजा हूं. इसलिए शेर जंगल का राजा है. किसी इलेक्शन ने, किसी ईवीएम मशीन ने शेर को जंगल का राजा नहीं बनाया. शेर मानता है मैं जंगल का राजा हूं, इसलिए शेर जंगल का राजा है. मेरे प्यारे प्यारे बच्चों, तुम बस मान जाओ कि 4 जून को तुम पास हो जाओगे। सिर्फ मेरे कहने से इतना मान जाओ, 4 जून को हम पास हो जाएंगे और तुम पास हो जाओगे। शेर जंगल का राजा केवल इसलिए है क्योंकि शेर का बिलीफ सिस्टम बहुत स्ट्रांग है। शेर मानता है कि मैं जंगल का राजा हूं, तुम्हें सिर्फ ये मानना पड़ेगा। इन 10 दिन में बिना टाइम वेस्ट किए अगर हमने रिवाइज कर लिया तो हम पास हो जाएंगे। सिर्फ इतना मान जाना। लेट्स मूव टू नेक्स्ट क्वेश्चन। Let's move to next question. Because of his attitude, wonderful Dr. Dopamine, this is why lion is the king of forest. Very good, very good. Because of his attitude. Because of his attitude. Next question. The CT of a patient. The CT scan of a patient with cervical carcinoma. So she is a patient with cancer cervix. And a CT scan was conducted in this patient with cervical carcinoma, and CT scan revealed a lesion which is extending to the lower part of vagina. Okay. So this lesion is extending to the lower part of vagina and there is extension to pelvic wall also. Hydronephrosis is also seen. What is the stage of disease I am expecting? Please everyone, quickly. Quickly. What is very good, wonderful. Everyone has answered D, that is, it is 3B. So if hydronephrosis develops in cervical carcinoma, it is 3B. It is 3B. Let me quickly revise the staging of cervical cancer. 1A1. 1A1. How much? Less than 3 millimeter. A2, 3 to 4 millimeter. B1, 5 or more than 5 millimeter but less than 2 centimeter. B2, 2 or more than 2 centimeter but less than 4 centimeter. B3, 4 or more than 4 centimeter. What is 2A? Upper 2/3 of vagina. A1 less than 4 centimeter. A2 4 or more than 4 centimeter. 2B, upper 2/3 of vagina plus extension to parametrium. 3A, lower 1/3 of vagina. 3B, extension to pelvic wall. 3C1, pelvic lymph nodes. 3C2, para-aortic lymph node. 4A, regional metastasis, either to anterior region urinary bladder or to posterior region rectum. 4B, distant metastasis. Few chocolate questions of cancer cervix staging. If a patient of cancer cervix presents with inguinal lymphadenopathy, what is the stage? Chocolate question. Chocolate question. If a patient of cervical cancer presents with inguinal lymphadenopathy, what is the stage? These chocolates are out of just my love and affection. I know you don't need chocolate, but I want to give you chocolate. So if inguinal lymphadenopathy develops in cervical cancer, what is the stage? 4B. Ascites in endometrial cancer, 3A. Inguinal lymphadenopathy in endometrial cancer, 4B. Vagina involved in endometrial cancer, 3B. छोटी सी बात दिल से निकलती है, बहुत डर लगता है. We are afraid of. How will we revise? How will we study? Whether we will be able to pass? जंगल का राजा शेर, हम सब पास 4 जून को. माना कि अंधेरा घना है, पर दिया जलाना कहाँ मना है. डर लगता है, दिया जलाओ रिवीजन का, दिया जलाओ पढ़ाई का, दिया जलाओ स्टडी का. माना कि अंधेरा घना है, पर दिया जलाना कहाँ मना है. Lighten the lamp. Just revise, revise, revise. Utilize these 10 days. And the last question of today's session. A 19-year-old girl. Her age is 19 years, presents with primary amenorrhea. Okay, she presents with primary amenorrhea and cyclical pain. Cyclical pain means pain during menstrual cycle. Breasts are normally developed. Secondary sexual characters are normally developed. On per-speculum examination, tense bluish bulge is seen. A very important, very frequently asked question. Tense bluish bulge is seen on hymen. What is most likely? Bachcha janta hai. Give me the answer. D. Everyone has started bombarding the answer. This is imperforate hymen. Why it is not Mullerian agenesis? Why it is not Mullerian agenesis? Mullerian agenesis patient will not complain of cyclical pain. Per speculum examination, there will not be any bluish bulge. Why it is not Turner syndrome? Turner syndrome, breasts are not normally developed. Secondary sexual characters are absent in Turner syndrome. Kelemen's secondary sexual characters are absent. No bluish bulge. And moreover, what clue will you get with Kelemen? Anosmia. She is unable to smell. And how does this picture look like? A very, very important question for our exam. They give you this image and ask you what is the most likely finding. This is the image of imperforate hymen, and you can see very well. Tense bluish bulge, very, very important image question for exam. Tense bluish bulge, this is a clear case of imperforate hymen. And lastly, I would like to say to all my FMG, dear loving students, जलने वाले जलते हैं, जलना उनका काम है, जला जला कर राख कर देंगे, FMG हमारा नाम है. एक बार दोबारा बोलता हूं, जलने वाले जलते हैं, जलना उनका काम है, जला जला कर राख कर देंगे. इतना पढ़े हैं हम, इतना पढ़े हैं हम, और इन 10 दिन में इतना रिवाइज करेंगे हम कि जला जला कर राख कर देंगे. FMG हमारा नाम है. With all these words, I would like to take a leave and wish you all the very best for your exam. Bye-bye. Take care. Wish you all the best from my heart.